get this ready. All right, so this is Dr. Hopkins, and we are here with Dr. George Rodgers. George is a great friend of mine. He's a fantastic colleague, literally one of the smartest people I've ever met in my life. George graduated from Harvard. Okay, if that wasn't good enough, he got into the hardest medical school to get into in Texas, at least, and that's UT Southwestern Medical School in Dallas. He then went to Baylor College of Medicine in Houston, where he got a cardiology fellowship. So he's boarded in internal medicine and fellowship in cardiology. He's written at least 40 clinical papers, probably more by now. He's been the chairman of the American College of Cardiology Board of Governors. George is literally at the top of his game in cardiology. He's been doing it a long time. And what I admire most about George is that he is a very down-to-earth person who patients absolutely love and adore. And so George has agreed to come on here and just review the advanced cholesterol panel. And we're super happy, George, to have you on here to review that. So what I'm going to do is just maybe kind of have you tell us a little bit about what your current practice is like, what you do currently, and then I'm going to share the advanced lipid panel and have you go through and look at us and tell us all about it.
Okay, well, thank you. And Alan, thank you for that very generous introduction. So I'm a practicing cardiologist. I've been practicing in Austin for 30 years now, and the last 6 or 7 years have been involved in the faculty, now on faculty at Dell Medical School at the University of Texas, and associate chief of the cardiology division. And so medical education is something near and dear to my heart, and prevention is also a great interest of mine, and as a result, biomarkers are a great adjunct to prevention and knowing really getting a better idea of what cardiovascular risk people have. And sometimes we can identify some things that we can change in terms of diet or supplements or medicines that might change the trajectory. So why don't we go through the lipid panel?
Okay, all right, let's do it, George. So I'm going to bring up the advanced lipid panel, and I'll just preface this by saying this is actually my cholesterol panel from the very last time that I had it checked. And so when you see all these numbers that look concerning, you can tell me what to do. I'm totally happy with that. So you can sort of even pretend like I'm in your office, but I'm very specific about I want to know the details behind each one of these biomarkers. And if you could just please explain them to me so that I can understand what I'm looking at.
Sure. So the first panel, I really like the way this is organized. The first panel is, pretty much of a standard representation of the lipid panel. The sort of the core of that is the total cholesterol, the HDL cholesterol, triglycerides, and LDL. And then below that, you see a cholesterol to HDL ratio, and then a non-HDL cholesterol. We'll talk about those in just a second. So total cholesterol, we would like for that to be less than 200. And the HDL is the good cholesterol. And we want that to be as high as possible, and in men higher than 40, and in women higher than 50. Triglycerides, these are fats in the blood, and we want them to be less than 150. And then LDL cholesterol, in most laboratories, that's a derived calculation based on the total cholesterol, the HDL, and the triglycerides. And so you'll often see LDL cholesterol dash calculated. I believe in this laboratory it's directly measured. And we want that to be less than 100. In people that have LDLs that are greater than 180, we often think that perhaps they have some more of a genetic problem with cholesterol, sort of a heterozygous familial hypercholesterolemia. So, the super high ones. And then, of course, the homozygotes are going to be enormously high LDLs, 3 to 400 plus LDLs, and total cholesterols of 600, 700, and so on. In this core representation, there's you can think of it as having simply hypercholesterolemia, which would be an elevation of the total cholesterol and an elevation of the LDL. In mixed dyslipidemia, that's characterized by high triglycerides and low HDL, and that leads us to the LDL particle sizes, and we'll talk about that in a second. So the cholesterol ratios, again, that's trying to sort of give us a balance, the cholesterol divided by HDL, kind of a balance between the total cholesterol, which of course includes the bad cholesterol, and HDL, which is good. And so you can see that the optimal would be a ratio of 3.5 or less. Non-HDL cholesterol is basically what they're doing here is taking everything but the good cholesterol and just saying, this is the whole bucket of bad cholesterol, and we want that to be as low as possible. So we want that to be less than 130. And so those are things that kind of give us a picture of where a patient's at in sort of general terms. But you can drill down further on that and look at the lipoprotein subfractions, and a number of ways to do this. And one way is to look at the overall LDL particle number. And by doing that, you're basically saying the more LDL particle numbers, the more potential damage we're going to be doing to the endothelial surface of the arteries. So the higher the number, the worse the situation or the greater the risk. That kind of correlates with small LDL. In other words, if you have a really high LDL particle number, it's because you have a lot of small LDLs. And the small LDLs are considered the more threatening or the more toxic ones. The large LDLs, the more buoyant ones, are considered the safer ones. And so if you have predominantly small LDLs, you're going to have a high LDL particle number. And that kind of pattern actually typically goes with the mixed dyslipidemia. So the triad of mixed dyslipidemia is going to be high triglycerides, low HDL, and a high LDL particle number, or a predominance of the small LDL particles. Going on in the subfractions, HDL, it turns out that the larger HDLs are the more beneficial, and you can see the optimal is going to be having greater than 6,729 nanomoles per liter. That would be the optimal. Going down one more category, and that's the apolipoproteins. So the apolipoproteins are these markers on basically the bad lipoprotein particles. So LDL carries this marker, and some of the very low density lipoproteins and so on carry this special little protein, apolipoprotein B. So the more bad apolipoprotein you have, the greater the risk. And there's also apolipoprotein A, and that's a marker that is on the HDL, where it's not shown here, but that's just so you know. So good cholesterol is apolipoprotein A, bad cholesterol, apolipoprotein B, B for bad. It's actually B because it comes after A, but I remember it that way. And then a very interesting one is lipoprotein little a. This is a very interesting one, felt to be genetically determined in terms of whether it's high or not. And if it's high, that can be really a significant risk for the patient. Lipoprotein A, not only does it, when it's oxidized, cause injury to the endothelial surface of the vessel, but which is bad, but it also tends to be more thrombogenic, and of course clotting in an artery is always bad. So it's kind of a double whammy when you have a high level of that, and it does correlate with higher risk. And then I believe there's a couple of other things, if you could scroll down. Yeah, so inflammation, well, the current paradigm for atherosclerosis is that it's an inflammatory paradigm. The trouble is it's difficult to measure inflammation within arteries, but we think that's really what's going on, and that atherosclerosis is really a tissue response to that injury or inflammation at the surface of the vessel. So Paul Riker took kind of an old test called C-reactive protein, which we've been familiar with for decades, and said, I wonder if we could really actually get a measure of vascular inflammation if we looked at the very lower end of C-reactive protein. So, the typical person with a flare-up of rheumatoid arthritis will have a C-reactive protein in the 30s and 40s and 50s. But if you have vascular inflammation, it's going to be in the far lower range. So it's going to be under 3, and even under, in some labs, 1 to 2 is considered a risk. So this is another way of looking at risk. So in obesity, which we know is an inflammatory state, we'll often see C-reactive protein significantly elevated. Obesity or metabolic syndrome, if you will. The next one is there's a couple of metabolic markers, homocysteine. We've known for a long time that people with homocystinuria, super high levels, determined genetically super high levels of homocysteine. These are people that have an inability to break it down. Homocysteine high levels are a risk for vascular disease and atherosclerosis. So a homozygous person, somebody who has 2 bad genes, will often have super high levels of homocysteine. Heterozygotes will have intermediate levels, but still a risk for atherosclerosis.
So when you look at this, George, being that this is my cholesterol panel, and I were to come see you, you're my cardiologist, assuming that I had no other risk factors, in other words, I didn't smoke, I was a normal BMI and so on, is this type of a cholesterol thing alarming to you? Is it something, like, what would you tell me if I just came to your office about this?
Yeah, well, I would say that it's got some good news and some bad news. And, when we look at homocysteine, that looks great. The inflammatory marker, very low. Lipoprotein little a is low. Some of the things that are driving the elevation are that we're seeing some elevation in total cholesterol, in the LDL, and of course that distorts the ratio of HDL to LDL, and there is some more of the small LDL particles than we would ordinarily like to see, and because the total cholesterol and the LDL are elevated, of course, the apolipoprotein B is elevated as well. So the question then comes, well, what do you do about it? There's, in terms of diet strategy, we right now we feel that the best diet to be on is the Mediterranean diet. And that's just as an overview of that. It's characterized by predominance of, in the meat department, a predominance of fish, followed by some poultry, and essentially no red meat. Olive oil for cooking, 5 servings a day of vegetables, and a serving is what you can put in your cupped hand. 2 servings a day of fruit. 4 servings per week of unsalted nuts, and 2.5 servings a day of whole 100% whole grain. So that's basically the Mediterranean diet. It's been compared to the previous low-fat, low-cholesterol diet and has been the winner in terms of both primary prevention and secondary prevention. And so that might help in this circumstance from a diet standpoint.
I wonder just how much you see changes when somebody comes in, and of course they're eating French fries and potato chips, and they self-admit to eating very unhealthy. By asking them to change the diet and their dietary approach, how much can these markers really move in your experience of seeing thousands?
Yeah, right. So I would say probably no more than about 15%.
Yeah.
I see them move, but not tremendously.
So it seems to me like largely this is genetically determined. In my family, I can tell you that, we have a really bad history of hypercholesterolemia in my family. And diabetes, by the way, which I yet do not have. But certainly genetics seems to be the primary driver behind a lot of my bad numbers here. What can I was going to say, what can I do to actually, so that's one thing. So I could do I could do a diet and that might help it. What about, is there anything I can do to bring that HDL large number up? Because that seems to be, HDL being the good cholesterol, I want to drive that number as high as possible. Are there things that I can do specific to HDL?
Yeah, right. HDL is a tough one now. We know that exercise will increase it some. And so that's, a non-pharmacologic thing that you can do for it.
Yeah, and I wonder, is there a certain type of exercise that studies have shown works better if I do, say, high intensity exercise versus just, walking, 10,000 steps a day? Or is there any exercise?
Yeah, we usually recommend aerobic exercise, 150 minutes per week of aerobic exercise, something that's going to get your heart rate up above 65% of your predicted maximum for 150 minutes per week. Most people do that as 30-minute sessions 5 times a week, and that certainly could help. And if there's an opportunity to lose weight, in your case, I know there isn't because you've always been trim, but people that are overweight, losing weight can improve HDL. And then from a supplement standpoint, niacin can boost HDL. Now, I would say maybe about 7 or 8 years ago, we had a lot of enthusiasm with using niacin in high doses, like up to 2 grams a day. But because we knew that it would increase HDL, and the feeling is that point for point, or milligram per deciliter per milligram a deciliter, HDL is probably 3 times more important risk-wise than LDL. And we knew that niacin would boost HDL levels. It would also reduce our triglycerides and reduce our small relative to larger LDL particles. So from a metabolic syndrome kind of perspective, niacin seemed to be like the perfect drug for people that had metabolic syndrome and mixed dyslipidemia. So there was this gigantic international study that was done about 5 years ago, and what they did was they took patients that had basically mixed dyslipidemia, and they put half of them on niacin plus a statin, and half of them on statin alone, no niacin. And they wanted to see, does it change anything in terms of having heart attacks or not. And it was a 5-year study, and what they found was that it didn't change the heart attacks, the heart attack rate or mortality. It did move the numbers. There was no question about that. I mean, it did actually boost the HDL levels and decrease the small LDL particle sizes and lower triglycerides. It did all the things that we knew that it would do, but it didn't change the mortality or the rates of heart attacks. And so there was a lot of loss of enthusiasm about using niacin and its long-acting variety niaspan as a result of that. The thought was that basically all of the risk reduction that you could achieve was already achieved with the use of the statins, and that's why you didn't see any incremental benefit from doing that.
Yeah, and the question that I had specific to that study was, were these people that already had known cardiovascular disease? I mean, because they were put on a statin. I mean, I'm just curious, was it done for primary prevention, or was it somebody who already had an event and they were looking to see if they suffered another event?
That's a good question. I'm trying to remember. I thought it was a primary prevention one, but I'm not really sure. I think that it was primary prevention because usually I remember it was an enormous study. 20 to 30,000 people were enrolled, and those kind of numbers, that's what you need for a primary prevention study.
Oh, yeah. Well, the really interesting thing, I mean, specific to niacin, and every time I've tried to use it, is that people generally do not tolerate those high doses of niacin.
Right.
So, it's impressive that a study was actually put together with really high dose niacin where they could get enough people who would actually take it for long enough. In my experience, 70% of people get the flushing and they feel like it's an allergic reaction. They just can't take it.
Right, right.
By the way, I tried niacin at one point. I tried niacin because I wanted to shift more to my HDL large, and I wanted to change my particle size. I wanted more, light, fluffy, large LDL instead of the small, dense kind. And what I found is I just couldn't tolerate the dosing. And so my real question is, how much of this is important to know about earlier on in your life and control the risk factors that we have? Because when we go in and see our doctor, it's always, a statin or not a statin. That's what it seems to come down to. And for a male my age, it's, are you going to take an aspirin because I'm over the age of 45? And am I going to have consideration for a statin to try to lower this? Because a lot of it's genetic, and, and I eat pretty well. So, I feel like I can't control a lot of this without some help. And so in regards to a statin and aspirin specifically, which is kind of the discussion that has been, looking at my numbers specifically right now, would you tend to trend them over time before you go further down that road? Or what does the data say? What does the science say right now?
Yeah, right. So there's a couple of ways to approach it. One way is to, well, first of all, I mean, we try to do everything that we can non-pharmacologic. I mean, we try to do all the right things in terms of everything we can do in terms of diet and exercise and achieving the ideal body weight. And if we still have some levels that are concerning, then we see if there's any further information in terms of risk stratification. And so one of the things that I really like to do in terms of risk stratification in men that are over 40 and women over 45 is to do a ultra fast CT scan or we call it heart health ECT, to look for coronary calcium score. And there's some very, very good prognostic information with regards to that, because, just as with your panel, there's some good things and there's some not so good things in here. And the question then becomes, well, how's that all playing out in your coronaries? Is there any evidence that you're developing plaque? And we have an enormous amount of information on this test to get an idea of what's high, what's low, what's expected for your age and gender. And if you have a 0 score, in other words, no detectable plaque at all, we know that the chances of having a heart attack in the next 5 years are probably less than 1 in 50,000. And that probably doesn't make sense to use medications like statins with that lower risk. That diet alone, the Mediterranean diet, would probably be all that you'd need. On the other hand, if you had a score above 400, or you, and the 2013 cholesterol guidelines say a score above 300, and you are in the 75th percentile for your age and gender, that's the highest quartile for in the bad way, then we would say you could probably benefit from taking a high potency statin. And that would be atorvastatin 40 to 80 milligrams a day, or rosuvastatin 20 to 40 milligrams a day. And when you have that higher risk. So, and really ever since the 2013 cholesterol guidelines came out, the philosophy has been match the statin with the risk. And so that's one of the ways to do it. Now, from a biomarker standpoint, one could justify perhaps going with a statin if, for example, the high sensitivity C-reactive protein was pretty high, above 3, or the homocysteine was high, or maybe even more importantly, the Lp(a) was very high. Those things we know are associated with much greater risk. And one of our ways of lowering risk is with statins. So that's something that we, might be a tip-in factor. So that's usually the approach. The calcium score, I've just been very familiar with it over the years. In our area in Austin, it costs $75 for the entire test. So it's hard to beat the value of that. I mean, it's so inexpensive, so easy to do, very little radiation that, you could just check in on, is there plaque developing in the coronaries, and if so, how much, and how do I compare to my peer group?
Yeah, that's great. I'm glad you mentioned the lipoprotein A, because one of the things that we always talk about is, get screened for lipoprotein A, because people just don't know what their lipoprotein A status is, and 99% of people have never heard about it. And a lot of primary care doctors don't know about it, and insurance doesn't cover testing for it. It's not an expensive test, and I mean, I'm on this crusade to get everybody tested for Lp(a), because I think it is such a huge risk factor. I've heard it's the equivalent of a person smoking a pack a day for 30 to 50 years. So
yeah,
it's a significant risk factor.
Right.
And wouldn't it be great to know about it if you're more likely to form a blood clot too? I mean, it's not only a risk factor for heart attack and stroke, but also for DVT and pulmonary embolus. So it is
right.
It is a risk factor. And then coronary calcium scoring can be helpful with people who have high levels of Lp(a), just to risk stratify.
Right.
So I know that you agree with me. We like a very comprehensive approach, and we like a natural approach before we have to go to pharmaceuticals. But pharmaceuticals have shown
Mhm.
that they can be very helpful for the right person. And
Right.
so being able to look at a person's sugar status, their inflammation status, and then their cholesterol status, and then follow it up with maybe a coronary calcium score to really get an idea if plaque's already there, is what I'm
Mhm.
hearing you say. So
Yeah. Mhm.
that's pretty
Absolutely.
awesome. So
Yeah.
my take-home message from your brief consultation here is that I need to go get a coronary calcium score, and I could try to eat a little better and see if I can get the numbers down and
Mhm.
follow it over time. But a coronary calcium score, if it's a score of 0, then how often would I recheck that? Would I recheck that every 5 years or just?
Yeah. 5 years would be that'd be a reasonable interval. Mhm.
Yeah, that's fantastic. Well, George, I really appreciate your time and going over everything with us today.
Oh, sure.
It's great to get a person of your caliber to come and talk to our group about it. And, there might be questions that will come. So if you guys are watching this later and you have questions, just go ahead and put them below and I'll do my best to answer them. If I can't answer them, I'll forward them to George. Maybe he'd be kind enough to answer a couple questions for us. But
Sure.
George, really appreciate it. And again, thank you so much for coming on and talking with us.
Oh, happy to do it. Thanks a lot, Alan. Thanks for the opportunity.
Yeah, you bet. I would love to bring you back, George, by the way, as an invitation to talk specifically about coronary calcium testing and how it's done and really what it's looking for. And then
Sure.
again, just to refresh on what scores are and then when people should be concerned about their scores. That would be really helpful to this group.
Sure. Happy to.
Okay. All right. Well, you have a great day. I know George just got out of doing a catheterization, so he just cast somebody today. So he's probably got to go check on them, make sure they're still kicking. Sure they are if they're under your care, George.
Well, thanks a lot.
Okay.
Thank
All
you,
right.
Alan. Okay.
Okay. Bye-bye.